Thank you very much, and good morning, and thank you for the introduction. I would just like to appreciate the organizers for affording us the opportunity to present our study, and I'll be presenting on behalf of our colleagues listed there. We are going to be sharing with you the efficacy and safety of FTAF, given together with Cobicistat-Boosted Protease inhibitors in children aged 2 to less than 12 years and weighing between 14 and 40 kgs. And what we're sharing today are the 48-week outcomes. Right, okay. Those are the disclosures for me and my colleagues whom I'm representing today. I pointed where? I'm pointing in the wrong direction.
Yeah, let me try to point it. Need advice from the tech?
Point where? The big button. The big button is what I'm pointing,
yeah.
But
oh, there we go.
We're pointing in which direction? Some direction.
There seems to be a little funky here.
Yeah.
A bit. Lag.
Okay, so I need to go back. Okay, thank you.
Okay.
Okay, thank you very much. And so in the way of background, we know that NRTIs in combination with boosted PIs are the guideline recommended regimens for treating HIV-1 in children who are not tolerating or are resistant to INSTIs. FTAF, we also know, is approved in the US and it's given in combination with boosted PIs for adults and children and adolescents who weigh 35 kgs and above, and also with other ARTs for children who are 14 kgs and above. And in the EU, FTAF is also approved in combination with other ARTs, including boosted PIs, both for adults and children and adolescents who are 12 years and above, who weigh 35 kgs and above. And we know that TAF is thought to be a better option than TDF. It has got improved renal and bone safety profiles. So cobicistat is a pharmacokinetic enhancer. It has no additional antiretroviral activity and can be easily co-formulated with other ARTs. So in the pediatric population, the safety and efficacy of these co-formulated drugs given together with PIs is limited. So in this study, which we call GS0128, it is an ongoing study that is a phase 2/3, it's multi-center, multi-cohort, and we are evaluating FTAF together with boosted PIs in children and adolescents with HIV. Somewhere, okay. So we are looking at 48-week outcomes for these children, looking at the efficacy and safety of FTAF, given in combination with Cobicistat-Boosted Atazanavir or Darunavir. And these are children who are between 2 and less than 12 years and weighing 14 kgs to less than 40 kgs at screening. And we call them cohort 2 and 3, which I'll define in the next slide. So I haven't gotten the direction to point this, but
Up there. It's moved.
It's there. Okay. Thank you. So this slide here just shows us the study design. And you can see that we had 2 cohorts. And cohort 2 and cohort 3. We looked at children who were virally suppressed, and these children had to have a CD4 count of 200 and above, and did not have any evidence of other infection, particularly hepatitis B and C. They had good renal function, and they were on NRTIs and had been stable for about 3 months prior to enrollment. Cohort 2 were 6 to less than 12, and cohort 3 were younger children who were above 2 years. And you can see that we follow them up to week 48, whose results we're presenting today. We did present the week 24 results at CROI. And the children who were in cohort 2 got the full dose of TAF, which was 200 with 25, and that was combined with Cobicistat-Boosted Atazanavir or Darunavir. And then the younger children got a slightly less dose of TAF, as demonstrated there. And the endpoints are on the side, which is showing us the efficacy with the viral load and the CD4 count. It also was, we're going to share the safety and the acceptability of this combination. Okay. Okay, this slide is just showing you the demographics of the population, and we can see that in cohort 2, we had 23 participants. In cohort 3, there were 26. And the mean age in cohort 2 was 10 years and 6 years for cohort 3. Mostly they were female and mostly black, and we see that they were mostly virally suppressed with good CD4 count, and most of them were vertical transmissions, and they were relatively well patients at enrollment. Okay, so just sharing the efficacy outcomes at week 48, you see that looking at both cohorts, for the patients whose data we had, they were all virally suppressed. We had all the data for cohort 2 and a little bit missing data for one participant in cohort 3. And if you look at the CD4 count, both the absolute count and also the percentages, you will see that the patients were within the expected physiological range for the age groups. And this is going on looking at safety, and we're looking at the cumulative data. And you see that there are a number of AEs, but these were minor. These are small children coming in with upper respiratory tract infections or GEs, vomiting. But when we look at the more serious AEs, we see that when we look at drug-related AEs, there were few, especially the grade 3, grade 4. We didn't have any for cohort 2. And we had, I think, only 2 for cohort 3. And there were a few participants who had to stop drug because of AEs, and I think it was a total of 5 participants. And it was mostly hyperbilirubinemia and mostly related to atazanavir, which we know is a well-documented side effect of atazanavir. Okay, so when we look at the grade 3, grade 4 laboratory abnormalities, we see those 7 who had hyperbilirubinemia, but we also had a few patients who had a little bit of raised amylase, a bit of decreased neutrophils, but basically there was very little grade 3, grade 4 adverse events outside of the atazanavir-related hyperbilirubinemia. Looking at safety, and we're looking at the height, weight, and BMI, you can see that when you compare the baseline to week 48, both for cohort 2 and cohort 3, there were no clinically significant changes for all the participants by week 48. Okay, and this is looking at bone mineral density and renal function. We also see the same, that there were no differences between baseline and week 48. Acceptability, we were asking the caregivers in terms of acceptability of the tablets, and we find that the tablets were generally acceptable both in size and shape. So in conclusion, in this week 48 analysis of children with HIV, we were between 2 and 12 years, weighing 14 to 40 kgs. We found that FTAF in combination with Cobicistat-Boosted Atazanavir or Darunavir demonstrated favorable efficacy, safety, and acceptability. And all the patients maintained virological suppression through to week 48. And the safety was very good, renal, bone, and weight. There was no concern in all the participants. And like I said, it was acceptable in terms of size and shape. So basically, this data is actually supporting the need for further evaluation of FTAF in combination with Cobicistat-Boosted Darunavir and Atazanavir in children with HIV. Just want to acknowledge especially the participants who participated in this study, the co-investigators with whom we worked, and also the people who assisted in preparing this presentation, and the sponsors who are Gilead. Thank you very much.